axial image, which shows an L45 moderate stenosis namaste point. So we will be doing an L45. So this
all the dilators from biportal starts from this. The C arm, it is done by the third. Whenever chisel. So J point also I'll chisel. Flavum. Still flavum. So looks to be here. Okay, now it would have been done with monoportal. I would have been stuck. Again fragments. This process.
So we'll be starting our third case of the day. The case, I'll just show you the MRI and I'll discuss the MRI and what our plan for surgery is. So this is a 54-year-old gentleman who presented with left lower limb radiculopathy. His MRI, when we look at his MRI image, we can see an L45 PIVD. We can see an L. You can give me one. When you look at the MRI, lateral MRI, T2 sagittal cut, you can see an L45 PIVD with a slight inferior migration, which is consistent in the T2 axial image, which shows an L45 moderate stenosis with a slight fragment inferiorly, that is almost at the lateral recess area. You can see in this image. So our plan would be is to remove first remove the ligamentum flavum, decompress both the roots and address this fragment, which is the cause of pain. So we'll be doing a midline minimally invasive UBE approach. So in this surgery, what we are going to do is, first and foremost, feel the spinous process. So we have marked the spinous midline. Midline you can mark either using a C-arm or by feeling the spinous process. So when you feel the spinous process, if it is a normal build patient, you will be able to get hold of the spinous process in total. Okay, just feel the spinous process initially, mark points over the spinous process and just connect them. So that will be your midline. You can confirm it using you can confirm it in the AP shoot as well. Then what difference what we are going to do in this is, we are not going to mark the pedicles. We are just going to see, we are going to put this is a dilator. We are just going to put it, we'll be just taking a lateral shoot and we are going to see the namaste point, which corresponds to the spinolaminar junction of your corresponding level. Suppose we are going to do an L45 decompression ULBD. So we'll be putting this on the namaste or the facets. I'll show you in the X-ray where we want where the namaste point is and what exactly it's corresponding to. Can you show this? Can you show this? Yeah. No. Can you keep this? Yeah. Yeah, yeah. Okay, 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 okay. So if you look at the C arm, can you show me this? Can you give me an artery? Can you can you give me an artery? Yeah, this is yeah, here. So if you look at the C arm, this is a lateral view, and this you see the top of this. This is a namaste point. You see this? This top point, this at the top, this is the namaste, because this gives a sign like this. So this is a namaste point. So we'll be doing an L45. So this point literally corresponds to the spinolaminar junction. Why? Because this is the spinolaminar junction. This is the facets. Okay. This in AP view, suppose we are keeping it here. So in the lateral way, we cannot see the spinous process. We can only see this this bony structure. This is a joint. So this corresponds to the spinolaminar junction in your AP view. Okay. So our incision is going to be, suppose we need a gap of 3 centimeter between the working port and the scopic portal. Why? Because if your incision is very close, you will have difficulty in manipulating, and your instruments will fight against each other or hit against each other. So that is early triangulation. Okay. And we need an ample distance between both the working ports, that is between at least 2.5 to 3 centimeter. If the patient is obese, maybe slightly more, but on table on average 2.5 to 3 centimeter is more than enough. So what you take, the midline of your incision or between the working port and the scopic portal will be the namaste point. Once you got the namaste point, some arbitrary distance, maybe 1 centimeter caudal and 1 centimeter cranial, or 1.5 centimeter caudal or 0.5 centimeter cranial. Why we are preferring this is we want to get rid of that early struggle of getting the triangulation, because if you land go with this approach, you literally don't have to tackle with much of the muscles. You'll get a good field and you are directly going to meet the instruments together. So which we'll be demonstrating now. Okay. Yeah. No, no, Namaste point is not the working portal. Namaste point is midline between the working point under the scopic portal. Okay. Can you click your phone? No, yeah. Yeah. Phone आ रहा है हाँ no हाँ फोटो ले मम्मा या हाँ हाँ I think there is a phone somewhere there. हाँ can you click your phone? Yeah. Okay. Can you pass that this thing yeah. No, just to yeah, marker is done. Is it this thing on the screen? Is the screen open? Yeah. Yeah, Siam shoot. Siam shoot. Yeah. Yeah. Shoot, Siam. Yeah. Shoot. Shoot. Yeah. Yeah. No, just kept over the marking.
So the ear looks very thick.
Yeah.
Looks very thick. The moving up.
Sir, the mic, I think, mic you can give it to. Okay, okay.
So let connect with the mic.
Yeah, he's getting the.
Please connect mic to scope to connect so that once you do the triangulation, we introduce the scope. Scope white balance and everything. You look. This is a 4K camera. Wonderful. Great.
Let's connect the mic one minute.
Hey, can वो दूसरा next phone, other phone, not this phone. Yeah, another phone ना idea. One phone I given. The other phone use. Hello. थोड़ा सा snugly fit. Kind of put it in little tight so that doesn't have a feel of coming out. Yeah, looks fine. So am I audible? Give me the scope. Give me the scope. Pass me the scope. So how you should prepare your UBE system is left hand is for the left hand.
Let's see.
So the left hand is the camera is there. Can you connect with this camera? Can you increase the size of the zoom? Okay, that's fine. So water light source. You need to remove the connect the light source. Connect the light source. Connect the light source.
No, no. With this only.
Here. Behind that you change this camera. You take it there and you can push it.
Okay.
I need this camera.
Okay. Okay.
Dilators, Jesco dilators. Not the dilators. One from
White
Jesco.
balance.
Rotating carrison. All instruments should come up. Do you have a Mayo trolley? All these instruments, okay. That's it. I need a 15 number blade. 11 number. 11. Okay. Just keep it there on it. Give me a kidney twin there. And the dilators there. I don't need any extra puzzle my system.
Can keep this out. Yeah, we'll go with.
Water please. Some we have TURP set connected to that. Where is the pump? Connected.
Yeah.
Don't touch the tip. Just खाली introduce it inside. Apply some sterilium on it. So connect with the camera so that we can directly start. Looks good. Just keep the dilators and RF. No extra instrument needed. Drill, RF, and so are you ready? The scope pay with drill. Make the drills ready. Make the drills ready. The Metronic and the Arthrix. Both I need and RF. Keep it like this.
Can you pass the drill?
Serial wise रख लो.
No.
रखा है क्योंकि I think
Which
ये
is the
टूटा है.
Arthrex drill?
Is not same.
With the Arthrex shaver. 5 mm.
Okay, done. The RF 5 mm fluid and Medtronic drill. Show me the Medtronic drill first. Medtronic drill. अभी Medtronic रहने दो, मैं बोन्स बीच बीच में ले लूँगा. हाँ, उसका थोड़ा सा ये थोड़ा सा अंदर जाना है.
I think the sheet is only this much.
ठीक है. Medtronic drill please. Medtronic 5 mm coarse burr with bayoneted.
No, no. इसका कंसोल कहाँ पे? Can you connect the drill, please?
Connect the drill. Medtronic or striker, whatever you have is fine. Drill is ready. Show me the
sir.
drill. Just a moment. Keep the drill near to the sheath.
Can you connect the Arthrex shaver?
You can take my specs out. Thank you, sir. Connect with this system. Further down we can go. It
won't wobble, right?
So on the other normal one, can it go a little close?
Shorter handpiece.
On the sheet. This one, this length will be there. So okay, can we start?
No, wait.
So first thing you
can you
have
connect
to
the
see
shaver?
here, there are 3 midlines we have done. Am I audible?
Shaver.
So there are, can we give me a marker? Let me explain in the meantime once we're preparing the OT. So I don't take AP views until and unless the patient is obese. So this is a thin built patient, definitely a moderately built patient. So I'll go there and palpate the spinous process. I can very well palpate the spinous process. I'll take marks on the for the spinous process. So then second step is with my both the fingers I'll go and hold the spinous process like this. Can you see? I'm holding the spinous process. So I'm making 3 parts. One is a right midline, one is a left midline, other one is a midline. Can you see? So this is not basically the thick width of the spinous process. So I don't have to mark all these pedicle, big those lines, because I am a doctor. I cannot understand so many of points. So what, to make the things easy, first I'll take a marker. Just a normal one. So I'll see the namaste point. So namaste point marking shoot. So see, that's a namaste point. Okay, that's the highest point of the facet. So I'll take the mark. Can see, show the C arm.
No, you can show it like that.
Okay. So what I'll do, after marking the namaste point, I'll choose 2 arbitrary points like this. Can you see it? 2 arbitrary points. This is my portals. That's it. No extra point, no extra marking needed. So suppose you have a scoli and you are operating. This is not going to change anything because you are doing palpation and doing it. The spinous process never lies. The spinous process, if you have scoli, it will be rotated. So once you over, we can go ahead with the surgery. So which monitor? This
monitor.
So then you see how I hold my blade. Can you see? Okay, this is in the direction of triangulation. I'll make a small incision like this. Okay, done. So you see my size of incision, it's very small. Mop, we go there and do this tactile feeling. So it won't take much time for me to do the triangulation. Give it. So these are specialized dilators from Jesco. You don't have to have bigger incisions or bigger markings for this. Okay, Just dilate. So I'm in the midline, so no multifidus is poking my movement. I'm just medial to the multifidus bunch of muscles. That's it. No big dilatation needed. The original old dilators from biportal starts from this. We end in this. So makes our surgery more minimally invasive. So I've done, the first part is done. Then give me another blade, please. Blade, please. Knife, please. So once you are done, my working portal is done. Now I'm going for this copy portal. Small incision. That's it. Just see at the two incisions. My little finger and incision. My little finger and incision. Okay. Same dilatation process. Go there. Palpate this one. Take a shoot. Now I'll be exactly at the namaste point. Show. See, I'm exactly at the namaste point. It is not done by the C arm. It is done by the third eye. We call it the tactile feeling. With a tactile feeling, you can bypass a lot of steps. No need to see. Just feel. So, okay. So the half part is over. Now saline will on. So first see, it is very important to focus on the saline. So you can see this should be like this projectile flow. Projectile flow. Can you see? A projectile flow, not dripping like here. This projectile flow. Okay. Now you take the RF. So do you have a watch? You watch how much time I'll take for the triangulation. From here, RF is working, right? So from here to triangulation, let's start. We're going there. Ablate. Ablate. Ablation, please. Arey, ablate. Arey. So you can see the here very well. So it doesn't take much time to triangulate. Ablate. So we have started the surgery. So now I'll show you the C. This is a sewn space top. So you see only loose areolar tissue here. Ablate. So now we'll go see this C. You see the C now? Saline, please. You see the C? So the base of the C is the base of the spinous process. You see from here to here is the C. Ablate. Stop. Give me the drill. RF. अरे drill कहाँ से drill करें? Drill?
Give the drill.
अरे how to drill this? Do you have a foot switch? Give it to. अरे change the saver to. Drill. अरे they give me the Mytronic drill here. अरे यार ये foot switch. Please keep the instruments in order. Which foot? So this is a technique which we call as, you cannot see anything. Can you? Can you see anything? Yes, that is known as blind drilling. So what is blind drilling is tactile drilling. You feel the bone and drill. Okay, so it is safe, very, very safe. If you feel and drill, it is very, very safe. Okay, coagulation please. So you see I have drilled the base of the spine's process. Coagulation. Coagulation. Some oozing is happening. Okay, so you see the vision. I am drilling the base of the spine. Carrison, please. Very well seen. So go there and enter. You see the. Give me the drill. So phlegm you can very well seal. This is the mind drilling we are doing. No, but you should learn it. You should learn it because you can do slowly once you graduate over 30 cases, then think about me. It's drill. So when people ask me, who is your mentor for biportal endoscopy, I say Dr. Kanta Glim. So if so people know them, they will laugh because he is a one world famous monoportal surgeon. He is a world famous monoportal surgeon. I do the biportal the same way he does monoportal. Drill, please. Can you give it to me? Because all these ablator, please. All this surgery, coagulation. So this is the area you encounter a facetal artery. So whenever you encounter this kind of heavy bleeding, go there. This is the upper part of the facet. You can see the facet joint. The capsule, coagulation. Give me the drill, Arthrex drill. Is it working? So either
Yeah, this
drill,
one.
please.
Can you keep this there?
So beware whenever you use a diamond drill, there is a chance you may injure the. So all this feeling, it may look dangerous, but it is not, because I'm feeling and drilling the way we do egg shelling in neurosurgery. Same we do. So Carrison, please. Arey, what is this? Please give me a straight Carrison, please. Don't change it. Anurag. So you see, I have drilled. Once you drill, then you go and cut it. Carrison though, na? What is normal? Normal Carrison. Okay.
Midline.
So because we are doing a canal decompression, so I have to go little up because I have to remove whole of the. So once you are here, give me the chisel. I'll show you what is under the cave work. Chisel, please, not straight one. Anurag, chisel. Give me the new chisel, curved ones, please. Chisel. So you don't need any drill. Curved chisel, please. Give me the curved chisel, please. Okay, this is a curved chisel, which is from Jesco. You see what is under the cave chisel. Saline, please. Whenever you see some, just 2 puffs. Okay, you see, we are doing under the cave work, like cavers go. Like the cavers go when they negotiate the tides of canal. Chisel, hard chisel. Chisel. Okay. So this is chisel's work. Chisel. This is only for the lamina. This side also we'll do chisel. Chisel. Okay. So yes, chisel. So morning I was saying the same thing. When you are at the SAP, you can use this curved chisel and remove that fragment. Chisel. Chisel. Drill, ablator, please. So once you are done with the upper part, you move to the lower ablet. There is another disc in the lower level. If time permits, I will do it by jump-in technique if possible. So now I move to the cranial border of caudal lamina. where the attachment of the phlegm will be there. Okay. So you see the cranial border of caudal lamina. Yes, give me the drill then. Here I use drill. You feel I'm driving a bike when I drill. Ah, drilling to my mind, not blind. Okay. Okay. Chisel please now. Now you eggshell it, then you hammer it. Chisel. Once at this stage, you will start seeing the dura. Okay. You'll start seeing the dura from here. Okay. Dural thecal sac will come. Carrison please. Carrison please. So now you see the thecal sac? You see it? Okay. So now my job is to go to the contralateral side now. And I'll remove the phlegm completely. Focus. Ablator please. Okay. Ablator please. Coagulation. So with me, Dr. Anurag is here, who was my fellow, and Dr. Anjar, what's up? Coagulation. So now I have changed my plan. From here I am moving to the contralateral side. Can you see? This is the caudal contralateral side. Coagulation. Can you see? Caudal contralateral side. Stop. Give me the drill. This is the spinous process of inferior lamina, and I have drilled the base of the inferior lamina. See? So there is a canal decompression. If you watch this, you can understand how things can be done very well. So now chisel please. Chisel. Saline please. Chisel please. Saline please. Chisel. So see, I've gone to the contralateral J point. Chisel. So you see, this is the ipsilateral J point, and that's the contralateral J point. Okay. Chisel. Okay. Okay. Carrison please. So you see the cavers bone is out. This is the cavers bone. You see the cavers bone is out now. Whenever you do biportal, we feel like we are doing scuba diving. So it gives you the impression of scuba diving. When we saline please, remove saline. One important finding I want to show. See, you are operating like this. If you withdraw your scope, you see this vision. If you bring it near, there is no blood. You see? Blood, blood, blood. Go there, no blood. So the scope, the scope should be very close proximity to the pathology. Ablator, please. Ablator, ablator, ablator.
Yeah.
Go.
Where?
Correlation. No, we use whenever there is the field becomes very messy, then only we ask them to give 2 puffs. 2 puffs of the TORP pump is enough. So sometimes these are soft tissue will come and poke to your field. Try to shrink it so that the field below it remains very good. Okay. Curate, please. Very good, very good. Whoever is working on the 2RP pump, many thanks to you. You're doing a wonderful job. So now we're lifting it. You can see the thickle sac very well while I'm lifting the phlegm from below. Carry on, please. Did you see any muscle poking into my field? No, because this surgery is done below the multifidus. Okay. So whenever you pull something, try to see underneath. You can very well see the thickle sac here, but I'm not going to the lateral ischius now. I have to work in the center first. Saline, please. Ah, very good. Okay. So I'm removing the phlegm layer by layer, not going underneath the phlegm. So see, this bone is hindering my view, isn't it? So what I'll do, see, chisel. This is what the basis of under the cave. We don't go over the top. We do under the cave. Chisel. So you see, you started seeing the corners, blind spots, chisel. Okay. Chisel. Okay. Chisel. So we are not removing the facet. We are just undercutting it. Okay, chisel. Stop. Chisel. Slow, slow. Chisel. You can use bone scalpel if you are comfortable. I used it 3 times, the blade broke. So now you see, now you can see what is this structure? Anybody in the hall can identify? What is this structure?
SAP.
Yes, yes. Dr. Anand Basu, it is not for you. Chisel, chisel, chisel. Then see, we are just chiseling the medial border of the SAP. Now you believe if you want to remove that in a canal stenosis, you have to cut it. But I don't cut it. I just do undercaving. You see, undercaving. Chisel, chisel. Like a self. We are building a self. Chisel. These are goldsmith's work. Chisel. Yes, that is what we are designed with Jesco. Curate. Once you do this, curate, curate, curate. Now, the most of the surgery I don't use much of the Carrison in the beginning phases, only I use Carrison. Then we use this to take out everything. You see how big is the phlegm? How big is the phlegm? So this phlegm we leave at the blind spot, patient will never improve. Carrison, please. You can understand, you can appreciate the clarity of surgery. It is clear, no saline infusion. Give saline, not needed. Sister, give some saline, not able to see. Words are not needed. That is what we do in open surgery in air medium. Yes. You see, that's a black coagulation. Coagulation. Now you see this area which you are seeing is after the under the cave's work. You cannot see this because this bone was hindering. So I removed it. That's why you are able to see it. Carrison, please. You can very well closely appreciate all the structures for the surgery. The saline is continuously flowing. Very easily it is flowing. Okay. So now contralateral, you can see this big flavum sitting there. I call it as a blind spot. Curved Carrison, we have that set, that one, that one. All this instrument you keep it here, here. Don't take it there. So you go there very close. So this I call, you see this structure from here, how it looks. Now you see it here, how it looks. Definitely much better. So this is the advantage of biportal. Okay. So my surgery is from midline. You can see my surgery is from midline. You see this blind spot which is sitting there. Oh. Still, you can see, still flavum. Still flavum. So much of flavum remains at the bigger calcium, please. So much of flavum remains near the exiting route. You can never imagine once you see it. We always take it for granted that we have removed all. But it is not true. The patient will tell whether we have removed it all or not. How? Just look at this fragment, big fragment. Still fragments remaining. Can you see? Without removing this, without the under the cave work, you can never see it. Now still see how much flavum is there. So I have to do some more drilling to reach at that level. Okay. This flavum you see, saline. You see, this is arising from the medial border of the SAP. Can you appreciate? This is the tip of the SAP. All these are compressing the exiting route. Can you see? Now you see from here. This is what monoportal looks like. Can you see? No. Now you see? Can we see? So this is what I was explaining, the advantage of biportal. The scope is smaller. The imagination, the imaging quality is better. So you can go closer, coagulation. This is a contralateral disc, you can appreciate. This is a contralateral disc. Can you see? And this big flavum sitting there. Big flavum. Carrison, please. Curved Carrison, please. Yes. So curved Carrison is a very handy instrument. So I'm just excising the tip of the SAP. If you do a CT scan tomorrow, you can appreciate. Okay. So much of flavum. You can see still flavum is there. Still flavum is there. See? If you don't remove, the patient will never have this beautiful working distance. How much flavum I am removing for blind spot? My thickle sac is here. 2 mm of or 3 mm of extra lateral recess we can decompress by biportal as compared to the monoportal endoscopy. And the vision is so nice, so augmented that you can see everything literally. Every corner literally. A small dural rent also will be visible. Okay. You see how much flavum was there. So what work we do is incomplete work. What work we are doing now is complete work. Now we go to the contralateral side, the ipsilateral side, sorry. Remove the ipsilateral under the cave work. Okay, ablator. Wide decompression is the key without sacrificing the integrity. coagulation, 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 coagulation. Drill please. Now, as the contralateral roots are decompressed well, I am going to the ipsilateral side. Drill foot switch please. So this is the roof which Dr. Basu was also drilling in the case. This is the roof of the J point or the roof of the facet. You do a CT scan tomorrow, you will understand how much facet preserving biportal is. This technique, wait for 5 years, with revolutionized canal stenosis treatment in all places of world. Ablator please. Chisel. So I'll J point also, I'll chisel. Chisel. Okay. Chisel. Garrison. Normal garrison. So my instruments are not hindering at any place. See, now we are going lateral. Just trying to see. Don't cut it here. I'm just trying to see. I want to use a garrison, that is known as no punch technique. That is the area where the maximum chances of dural tear happens. So chisel. Chisel is safer. Okay. Take a curate. See, I could have done it with garrison, but I didn't, because the chances of having a tear, even with chisel also there is a chance with the bone fragments may impinge on the root, but it is much less than a garrison, because if hold in a garrison, it's gone. So you see, this is the root area. So I'll garrison please. Now because we have moved to the rotating, not this one, the curved. So my vision is very close, so I don't need to see structures. Okay. Chisel please. So this area also, see what's wrong and how I manage. I'm trying to put my garrison here, it's not going. Is it going? Not going. So what I'll do, see, chisel. No need to push your garrison there. Just chisel. Okay. Now you see, I removed it. I don't need a garrison now. Curate. So those areas which are inaccessible can be very well handled with a chisel. Okay. So now you see we have reached to the lateral border. Okay. Sorry. So some more chiseling will expose that area completely. Garrison please. Garrison please, to take out that fragment. Which side the disc was there? Left side, right? So clear, everybody can appreciate every structure. No, it's so beautiful that the OT staffs can tell, sir, this is a nerve. This is the exiting route. Because vision is very good for all. Just no blood loss because chisel. Okay, chisel. You see this. Stop. Sure. Chisel, curate please. Very gently you have to do, because bone edges are also sharp. Sometimes it can impinge on the root. So move it towards upwards. Now it is okay. Okay. Garrison please. Once the surgery is over, all will feel that there is no extra work needed. Hook. Give me a hook. So canal is decompressed, we have removed everything. Now there is a disc. So I'll approach that. So I believe in these cases we need to have a little of extra bone work. Carry on please. Normal. Take it, take it. Okay. So give me the drill. Electronic drill please. So see, what additionally we'll do like this. I'll drill a little part of this bone. It is hindering my view for the discectomy. Just a medial part, not much of the drilling, just to access my scope inside. Here you go slow, I drill it under vision. Okay, okay. Give me the chisel. Okay. Garrison count, garrison please. So in these cases when you have a tight disc, big disc, do not approach it from the near axilla area. Go to the shoulder, up in the shoulder. So this is up in the shoulder. Okay. So from there, trace it down to the shoulder. Then you can do peri-axillary work. Okay. Hook please. Root retractor from Jesco set. We have a Roton micro set. So this is the disc area. Can you see? There's the disc area. Garrison rotating. Hold. So I'm working on the shoulder area. Carefully see. I'm working on the shoulder area. There's still phlegm underneath the thing. That also will remove. You see? Very closely I can see structures. Very closely. So all can see I'm not very less chances of damaging or misunderstanding a anatomy. So I'm just making a space there. Chisel please. Curved chisels is very handy for these situations. Chisel. So I'm not destabilizing anything and just undercutting it, making some extra space there. Okay, some extra space, millimeters of extra space. Chisel. Huh? Okay, millimeters of extra space. Garrison please. Is central or migrated disc?
Slight inferior migration.
Paracentral. Okay. Root retractor please. So this is no, not big one, small one. No, no, smaller one. So this is a root retractor which can be introduced through the portals like this, and we'll go there and rotate it. Try to make some space, but not there. So we have to uh, drill some extra areas. Garrison, chisel though. Chisel. Drill. Metronic. Very slowly you need to exhale this area. Slowly, slowly, slowly exhale. I have understood the limitations of the diamond drill, because we drill it near the, for drilling the linoid process. So you have to do it like that only, and there is definitely uh, saline all around, so no chances of heating. Okay, eggshell it, calcium. Yes, I'm de-roofing it. So why I'm de-roofing? Because the it looks like a big disc chisel. Okay, this looks like a big disc chisel. Okay, okay, chisel. So we just want to extend the laminotomy a little extra. Cure it. Change the water. Ah, maybe I wanted to be orthopedician. Who knows? Garrison, please. So clearer vision will allow you for precision. Okay, you can see how smoothly I am able to cut these structures very nicely from a close perspective. Okay, so we'll free some extra uh, millimeters of canal, because sometimes if we are not able to completely remove, so this bowstring effect of the compression will be gone. Uh, I think all patients are given injections before coming. Chisel, chisel. So this is the area where I need to work. This is the area, you see. So this bone I need to cut out. So this is not destabilized. Just make extra millimeters of chisel. Huh. Extra millimeters of chisel. Chisel. Cure it, please. Ah, that depends on surgeon. Whether there is no fragment, it looks like a hard calcified disc. Let's see. Let's see. Garrison, please. Anyways, the roots are free, but the disc has to be removed. Ah. Ablator, please. Root retractor, please. So extra millimeters only will help you to expose that area. Okay. So I don't find any disc. Okay. Hook. Well, maybe we have to extend the alignment. Left sided, na? So hopefully I'll make a laminotomy here. Shoot. No disc. No disc. Was it not a calcified part? Because the roots are free. The roots are mobile also. Content disc is there. Let's see. This is a contralateral disc, which is, I believe. This is a right sided disc, I believe. See? Is a left sided or right sided disc? Okay.
Left side.
Left sided. Ablator, please. I'll remove it from right side. Let's see. Central disc or paracentral? Coagulation. So see, this is the contralateral disc. I believe the disc bulge is here. Coagulation. Stop. Indian knife. Let's see. Let's see. I'll try to remove it from that side. Okay, shoot. Okay, so in the disk space. Okay, give me a down bite for disk forceps, not big one, small one. Hook. These are small. Do you have roton set or something? So I believe this disc was on this side because you can see the fragments are coming here. Carrison a bit. Carrison please. Carrison small. Carrison please. Small Carrison. Small Carrison. 2 Carrison. Give it. Give it. Okay. The bulge looks here. Looks to be here. Okay. Down bite. Down bite. Carrison you don't have. Down bite disc sponge. Do Jesco people have a down bite disc sponge? We need a down bite one. Down bite. Down bite. Up bite is fine. Up bite is fine. Up bite is fine. Up bite is fine. Give me the up bite. Give me a small up bite. So I'm removing the disc from this side. Give it to. Give it. Just big one. Small one I need. Small one. Small one, please. A small disc force. You should have a small disc force, up bite or down bite. Anyways, we're trying to remove it. See the disc. Okay. So, can you see the disc? So I'll remove it from here, and you'll see, because I believe it's not an extruded fragment, so all will come through this. Okay. So annulus is like a box. So anywhere, if you have a content annulus, you can remove all the discs from that side. Almost we are end of the procedure. So I have some vancomycin powder. Yes, every case. I am very scared of revision because it is biportal. I'm getting a lot of VIP patients. Any disc, any issue will kill me. So all this is standard of care, a drain, and we don't know, but my infection rates are zero now because I believe coagulation. Huh? Yes, I had, and mostly the infection are from. That is why we keep all the camera system, everything sterile. So we cannot afford an infection. Very scared. Open, opens, open. It happens. It's fine. But biportal we coagulation is on an annuloplasty. Hook. Down bite, please. We'll remove some more disc. So any doubt anybody can ask. I believe gentamicin can be used, but I believe Vanco is a superior choice if you are scared. This is surgeon's happiness. Whether it works or not, we don't know, but that's the surgeon's happiness. So there is another disc below. Do you want us to remove? So we can do that. Is there time?
Uh, we'll check for any extruded fragment here.
I will look for the axilla.
Hmm.
Let's expose the axilla.
Hmm.
So Anjar wants to see some extruded fragment is there or not. So for him, I'll try to now expose the axilla. So I believe this is looks like to be axilla. Let's see. Chisel please. Uh,
I think he will finish it fast.
so Anjar wants to see the axilla. So this is the axilla. So definitely, so that is where we come to the exploratory abilities of biportal endoscopy. Chisel please. Chisel. Oi. Chisel. Chisel. Okay. Chisel. Carrison please. Carrison please. Chisel please. Curate please. Chisel please. Coagulation. I have never converted a biportal endoscopy. Coagulation. So the day you think of a beginning phase of career of biportal endoscopy to convert, then you can never understand biportal. Coagulation. It is very easy. Mind's ability is very easy. So now another thing, if you want to operate 4-5, 5S1, you can jump in and operate from here. Can you see? Ablate. Now just wanted to show you. I want to now operate the 5S1. I can operate from here. You see? You see? I'm going underneath. And now at 5S1, can you take a CM shot? Now you see. From there same level, I can operate 5S1. Can you see the CM? So we are at the Namaste point of 5S1. If you want to operate 5S1, you can operate it from here. Okay, so coagulation. That's not the job described to me today. So stop. Chisel. I want to explore the axilla. That is why I am just cutting this area. Chisel. Okay. Curate please. Curate. Because there may be a extruded fragment which we are missing. So if we have time, what is the time? You have 10-15 minutes and we can explore.
Yeah.
4 o'clock. 4 o'clock. 3:40. So we'll explore the axilla. So you can see this is the exiting route, and I believe that is what I wanted to say in the morning. Okay, when there is a canal stenosis, there is telescoping which happens. Now normally the route, the axilla should be here, but now you can see the axilla has gone down. This is because of the telescoping which happens at that area. Okay, that is why we have to extend here laminotomy a little. Carrison please. So this is looks like to be the axilla. Drill, drill. I'll expose the axilla because I cannot take chances. Coagulation please. So just extra work I'm doing. I don't know whether this extra work is not needed, but anyways, just wanted to see the axilla well because Dr. Anjar is very fond of axilla. So coagulation. So where the bleeding is, Anjar is fond of axilla. I am not fond of any axilla. Stop. Hook. So can you see the axilla here? I need a smaller. So can you see the axilla here? That is almost the axilla. So we will see, is there a fragment? Yes. Is there?
Mm.
Is there? Fragment is there, Baba. It to work.
Yes. Slightly more of
Now
osteo.
we'll go to the axilla.
Mm.
Carrison.
Yeah.
No, drill. Chisel though. Chisel. Carrison. Root. Chisel. Stop. Huh. Okay. Curate. Very very slow because these are tighter areas. Any wrong step can land up in dural tear. Even it happens dural tear, I can manage it with hanky in the pocket, but we should avoid. So this is the axilla
That's the
area.
axilla. Yeah.
You can see the axillary pad of fat, and this is the exiting route. Definitely it is hinged, so there must be something hindering our work. Ah, okay. I can find the annular tear now. You can find the annular tear here. Okay, give me a hook. Carrison, please. Chisel, please. Carrison, please. Chisel. So, do you have a smaller? Do you have a roton set micro dissector or something? Roton set do you have? Coagulation. So I'm just coagulation, coagulation, coagulation. Okay, coagulation. Okay. Carrison, please. Chisel, please. So this work takes a little time. We're almost done with the work, but we're just exploring. Chisel. Okay. Chisel. Okay. Curate, please. Curate. Chisel. Chisel. Curate. 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 Now, once you have the exiting route in the hand, traversing route, the work becomes little easier for you. Bone wax you have. So that's the axilla.
Now it's getting free.
So little more of exposure will be better. Just Carrison, please. So you can see how hinged the roots are at that point. Yes. Coagulation, please. So you can see the vessel, how it is bleeding like a snake. Snake mouth. Coagulation. Coagulation. Snake coagulation. So it is safe to have coagulation on the dura. Carrison, please. Little more of the bone removal will help us. We are not stopping. That is what the point is. Even if we have finished decompression, did a discectomy for contralateral side, but we can still explore. Oh, no. Coagulation, please. Curate. Can you have a artery or something or okay. Microsite is there. So this is the axilla. Okay. Carrison, please. Microset to roton microset, please. You see the hitch. Ah,
Hmm.
that is
Yeah.
what we are
Will
exploring.
yeah.
The what you see, I am also
Yeah.
seeing
Root
that.
hummed up.
So
Maybe. Yeah.
yes,
The root
yes.
is pushed
Now
posteriorly.
you see, this is the area where yes.
Yes.
So I can poke that and see what is that. Huh? Now you see. Okay, root retractor, please. It is there. The fragment is there. Disc forceps. Small disc forceps, please. Now, surprisingly, I can see the annular tear here. The tail is coming out. Root retractor, please. So now we are exposed a better length of the root so that we can manipulate it a little. Okay. This forceps, please. Hold it like this. Don't move it, huh? This sponge. Up bite. Ah, ha, ha.
Yes.
Ah. So you can complete the work with biportal. Now, if it would have been done with monoportal, I would have been stuck with all these scenarios of not visualizing anything. This is the power of the 4 mm scopy. I would have missed it on I have done it with monoportal. You can appreciate now why biportal. If there was there, I could have no explained them very well. I believe. I wanted a monoportal debate with monoportals. Ah, oh my God. So complete work. Go home happily. Your patient is safe. You can counsel the patient relative. You have done a wonderful work. Please pay us well. So now, a bite please. A bite. So I believe the question Sridhar sir was asking is, I was trying to tell him the same thing. No, no, small upbite you should keep for a spine surgery one. Small upbite. Okay. So he can show us all the fragments. Now I believe till now the hitch must have been gone. Should remove. Now the hitch is better, you see. Okay, another hook, roton one, roton one, roton. This tip is very good.
Yeah. Now the root is free.
Even if there's something also, I'll fish it out. Nothing. So we are all clear कि we have removed it. Some more fragment if it is there, remove it that also. This forceps. So if you want, we can do the other level also. What to do? I think time is gone.
Other level.
More fragments are there. So any doubts, please ask. I believe I have done removed all queries from your mind ki of incomplete work. So completely we are done. Oh ho. Very nice. Lot of fragments.
Still
Okay.
fragments
So
keep coming out.
basically the contralateral work helped me to decompress it little so that I can take a video of operating panoramic one. सब मेरा 0.5 मिल. So is it okay? All are convinced? So that's the exiting route. That's the axilla. Oh ho ho, oh ho ho ho. Can you see? Can you see? Anjar, I
Yes.
believe you should give me a treat. Or I should give you a treat, I don't know. So I can go very close to the axilla and see it. Okay. Yes, sir.
Fragment. Hook.
Sir. Another fragment, saline.
Yes.
And the fragment is there, I believe.
Mm.
Coagulation, please. So all fragments almost removed. Will just fish out. So the biportal is a complete work. Coagulation. Coagulation. You don't have to guess anything. You just see yourself and do. Even our staffs can do biportal because it's so easy to appreciate structure. Coagulation. Saline थोड़ा देना. मैं axilla explore कर रहा हूँ. Stop. देना hook दो. Not this. So we can manipulate the axilla very well. We can manipulate the axilla very well. Again fragments. This forceps. This forceps, please. Another fragment. Okay. All fragments are out now. Okay, so I believe we have root hook. So this is the end of the procedure. You can see the contralateral disc. Okay. You can see the ipsilateral disc. Saline. Keep on giving. Ipsilateral disc. All fragments are removed.
Maybe just do a little bit of
I will
annuloplasty
do.
there. Yeah. Yeah.
All fragments are removed. This is the superior area. चलो इसको एनुलोप्लास्टी अनुराग कर देना थोड़ा do annuloplasty. So we can call it a complete procedure. इस तरफ से थोड़ा shrink कर देना. At the end of the procedure we do annuloplasty with RF. So bones is a wonderful RF system coagulation. So we do annuloplasty to shrink the annulus at the end of the procedure. The pain originating from these nerve roots and vessels from annuloplasty is taken care at the end of the coagulation. This is annuloplasty. It is not possible in open surgery. So RF helps us, plasma helps us to achieve this annuloplasty. We have till, so now this is the fat pad of the exiting root can be seen, and here also the fat pad of the exiting root can be seen. Okay. So this is a traversing root and the axilla of ipsilateral side and contralateral side. I believe this is the end of the procedure. I believe there is no leftover fragment. So we can call it a good surgery. Calcium please. ये निकाल देना निकाल के ये कर दो.
Put the.
Thank you so much. Any questions? हो गया क्या? Oh my God.
Yes.
एक फोटो ले लेते हैं. Just one. बस यही ले लेते हैं. हाँ हाँ. नहीं रखने दो. एक फोटो ले लेते हैं. You can take a picture. Mobile. Kamal. आ जाओ. Oh yeah, drain is a must sir for all cases because this is water medium surgery. So once you remove that water pressure, there is a chance. So drain. Okay. So Anurag will demonstrate how the drain is put. First, take. So now we put the drain like this. We take care उसको hinge करके portal में ले आना. So see exactly how we do. We put the dilator. Then through this we put the drain. Through this we put the drain. Okay. So that it can be directed well. ये photo
Yeah,
ले
it's
ले.
a mini vac.
आजो आजो. डॉक्टर ये नीचे है क्या? थैंक यू. आई थिंक पूरा निकल गया और जो सीधा सरका था मैंने वो क्लियर किया.